So at this time, we have, as I mentioned, 3 studies that have been published. We do have a database of 300 patients off study that we are treating in the clinic. So my impressions in terms of the efficacy is that it's an efficacious regimen. When we follow patients and we evaluate them based on the current guidelines that we have for response, over 90% of these patients will respond with a decrease in the serum IgM levels. Not only that, we have seen patients' anemia improving. We have seen patients' thrombocytopenia improving. Lymphadenopathy improves. Splenomegaly, hepatomegaly improves. So we have actually seen benefits on these patients. The quality of life of these patients improved greatly as well. So the efficacy is there. And obviously the depth of that efficacy, how long that efficacy lasts, is something to be seen as time goes by. We have, from our parent study, in which we have been following patients for over 5 years, not even half of the patients have stopped taking ibrutinib. They continue taking ibrutinib 5, 6 years out. So we feel the patients on the frontline study will have a very similar outcome in that specific situation. Now, the safety is different. It's different than the chemotherapy agents that we have used. It's just the fact that you have to take 1 pill every day indefinitely makes the side effect profile very different to what we are used to, we have been used to. So I would divide the adverse events associated to ibrutinib in 2 groups. I would say there's an early stage side effects and then late side effects. The early side effects that we have seen are typically nausea and diarrhea and rash and joint pains. Most of these symptoms will resolve within the first 2-3 months of therapy, and they will not be long-standing. The late side effects, there are 2 that we need to talk about that are probably important. One of them is the risk of bleeding. Ibrutinib does block the stickiness of platelets. It affects their addition and aggregation. So patients can bleed if they get exposed to a trauma or surgery while on ibrutinib. But this is easily manageable, as we could stop ibrutinib a few days prior, the day of, and a few days after any procedure. So depending how invasive the procedure is, we do have a specific durations of holds to actually minimize the risk of bleeding. So that is not too big of a problem. The other problem is a novel adverse event in the terms of arrhythmias. Atrial fibrillation is probably the most common arrhythmia in the country, without Waldenström's on or off ibrutinib. But we believe that patients on ibrutinib have a little higher risk of developing this arrhythmia down the road. And we see it a few years into therapy. It's not a very early problem. Now, there is some data showing that older patients or patients with prior history of arrhythmias or prior history of heart problems have a higher risk of developing this issue. While patients who are younger and don't have any other, they have a lower risk of having this problem, but it's something that we need to be aware of, and we need to learn how to manage it appropriately. So from what I've seen, ibrutinib tends to be a good agent. I mean, the patients specifically who have been previously exposed to chemotherapy or been exposed to monoclonal antibodies and have had reactions to them, or have previously been exposed to transplants and things of that nature, they really feel ibrutinib is the next best thing that ever happened to them. So, and if those patients are really well selected, so we know which one are they going to be the ones that are going to be deriving the best benefit out of this, then I think that's where the trick is, trying to understand really well who's going to be the best patient to derive benefit from this. So in our practice, about 60% of patients have MYD88 mutations without CXCR4 mutations. Those patients are feasible candidates for ibrutinib. I think those are the ones that will benefit the most from this type of therapy. And about 30% of patients will have a CXCR4 mutation. I don't want to say that those patients do not benefit from ibrutinib. I think they do. But there are other options that are equally effective, such as bendamustine or bortezomib in combination with rituximab. So we need to make some decisions in terms of what makes the patients more favorable in terms of how to treat them. If patients had no MYD88 mutation, then those are the patients that will not benefit from it, or will benefit the least from ibrutinib. And in those patients, I try to use rituximab combinations and whatever is more standard to treat on those patients. Now, specifically in this case, the treatment with ibrutinib should be indefinite. We don't have any data at this time that ibrutinib therapy can be stopped. And it doesn't matter how deep the response gets into. Every time we have tried to stop ibrutinib therapy, then it takes a few days for actually the IgM starts climbing. And in about 80% of patients, within 3 months, they are back to where they were at the beginning of therapy. So there is no reason really to stop ibrutinib therapy at this time, and our recommendation is to continue indefinitely.